We're here to talk about brain trauma. Brain trauma is pretty important to talk about because it happens to a significant number of people. It happens with auto accidents, it happens with sports injuries, it can happen by bumping your head on a cupboard. But brain injuries are very dangerous because a concussion can change a person's life. A lot of work has been done just recently on concussion, and the information that comes to the brain normally is supposed to control the muscles and the organs. We'll talk more about that in just a minute. But when that concussion happens and the information coming to the brain gets scrambled, or it does things that it shouldn't, or it doesn't do things that it should, that can change a person's life because of memory problems, or because of movement errors, or because of the way their digestive system works. It can change sleep patterns. It can change a whole bunch of things. So we're going to talk about a lot of that tonight. The question came up, what are all those letters after my name? The DCBCN is the Diplomate Chiropractic Board of Clinical Nutrition, or Chiropractic Nutrition. DABCN is Diplomate American Board of Chiropractic Neurology. DIBAK, Diplomate American International Board of Applied Kinesiology. DAAIM, Diplomate American Academy of Integrative Medicine, and FACFN is the Fellow American Chiropractic Functional Neurology Board.
Wow.
So I've been in practice since 1977, and I've been practicing functional neurology since 1991, and I love the neurology part of what I do, and we're gonna show you a lot about that today. So the brain has a little bit of information about the brain. The brain has about 100 billion neurons in the brain and spinal cord. So there's a lot of connectivity. That's just the neurons, and then each one of those neurons has connection with other neurons. So it's countless number of ways that the brain can put information together. We all have the same nervous system. We all have the same pathways that go from here to there, and we can dissect them out, but we all use them differently. We use them differently because we sculpt them in ways that make us unique. We sculpt them by not using a certain aspect of our function and using another one really well. Like, for example, if a person's right-handed, they're going to use their right hand, and that turns on the left brain, which helps them use their right hand even better. But when it comes to using their left hand, they don't use it as much. So the brain, we call it being sculpted away because it's not being used. The neurons that are related to the left hand aren't used as well. Then the neurons actually die off, and so it sculpts over time. And over time, we're sculpted right into the person that we are. It makes us more. Maybe it makes us less flexible in our activities. It makes us more interested in certain things and disinterested in other things. So that's an example of sculpting. Neurons receive, process, and deliver neurotransmitters. When the signal comes in, it comes in at the end of a neuron. Then there's neurotransmitters released into the gap between neurons that makes the next neuron do its job. So it's all designed toward putting neurotransmitters into the system. The left side of the brain controls the right side of the body, and the right side of the brain controls the left side of the body for the most part. But there's all kinds of maps in the brain. The left side of the brain controls the right side of the body, but we now know that the right side of the brain controls both sides of the body. The right side is very important. The right side is the content part. The left side is the context part. So we get the idea to do something on the right brain, and we get the decision to do something on the left brain. The right brain is the quiet brain. It likes to keep things subtle. The left brain likes to go out and investigate the world. So a person who has hyperactivity disorder, for example, might have a right brain deficiency, not keeping the left brain home, so the left brain goes out and does all its investigating. When we turn on the right side of the brain, it pulls the left side back in, and a person can be more normally functioning, what we call neurotypical. All right. So here's what used to be, I guess it still is in a lot of circles, an idea of what left side of the brain and the right side of the brain do. There's some modification to this, but for the most part, these are pretty clear. The left side is logical, linear, and the right side is pretty abstract. When it comes to brain trauma, brain injuries, 85% of the major illness, the incidence of traumatic brain injury is pretty high. You can see there breast cancer, HIV, and so forth, small aspects of people's health. Brain injuries are a big deal. So you can't see a brain injury. You can't see it with your eyes, but you can see it in the way a person moves and the way a person responds to their environment, and we'll talk about that. Falls are the #1 cause of incidental death. Accidental falls are a issue that we need to really be aware of in the very young and in the older people, and older is like 30 on. That is the 4th decade, you know. But in between, the highest incidence of death is actually auto accidents for kids learning to drive. So when it comes to TBIs, falling is a big deal. Auto crashes. We call this a contra coup. When someone gets in an auto accident, the head whips forward and then whips back, or if they're hit from behind, the head whips back and then forward. And this whipping of the head stretches neck muscles, but what happens inside the cranium is very important. Can you get the cranium, the skull for me that's in my office? So that the brain actually splashes against the inside of the cranium, and inside the cranium is there's a lot of prominences and there's a lot of bony aspects that could be very sharp against the brain that's very gelatinous. Thank you. It's plastic. It's not real. So if we take the head off, if you look inside, you can see that there's bony prominences of various kinds, and those bony prominences, especially up in here, they can be very traumatic to a brain, and the brain will bruise, or it can get torqued inside. If the brain stays still and the head moves, you know, it's going to cause a torque to the brain. So the brain stem is important. If it gets twisted, or if it gets affected or bruised, all of those things have their display. Of the sensory signal that comes into the cortex, approximately 85 to 90% comes from your muscles. So that goes to the brain. Of the outflow from the brain, approximately 90% goes to organs. It doesn't go back to muscles. So if you have a breakdown of sensory input because of a muscle being stretched or a trauma of various kinds, that will cause the signal that would have reached the brain to not be there. And then that outgoing signal can't do its job. And the brain's main function is to inhibit or keep things controlled underneath it. And if that's not excited to do the controlling, you're going to get what should be controlled, or aberrant motion. And that aberrant motion, dysfunctional motion, movement that shouldn't be there, or maybe thoughts that shouldn't be there, or thoughts that should be there that aren't. One of the big things people complain of is fogginess. Their brain is foggy. So that fogginess is one of the signs and symptoms that people have concussion. And then sports injuries. How many times do you see kids out on a sports field playing soccer hitting the ball with their head? How about every time you hike the ball in football? My parents always told me, we don't want you to play football. It's a contact sport. Stay away from it. Dad, can I play basketball? Oh, sure. No problem. Well, do you know what goes on underneath the basket? It's traumatic in itself, and there's no padding. So sports injuries are a big part of what causes traumatic brain injury. A concussion is a brain injury that causes temporary change in the way your brain works. Temporary change in the way your brain works. So it's acute right away, and then as a person gets better, they might seem like they're improving, but is that problem still there? Chances are it is. We hear about injuries all the time, and I have patients that come in to see me regularly complaining of brain trauma of some kind. Brain injuries are cognitive, they're behavioral, they're physical, and then they're perceptual. So there's a lot of aspects to them. Does every brain injury relate to dementia? No, not every one, but it certainly can relate to it because of a breakdown of neural tissue. So we're not going to be talking about dementia. We're not going to be talking about frank concussions. We're going to be talking about microtrauma. But I wanted to be sure and talk about dementia a little bit because it's a big deal these days. One of the main ways to keep your brain healthy is exercise. Exercise is the one thing that's found to be neuroprotective. Parkinson's disease, for example, when a person gets goal-oriented activity that they're constantly doing, like constantly 3 times a week, 4 times a week, but if you can do it daily, that's even better. But goal-oriented, to reach goals and to make sure it's the right kind for that person. And it's important also that when muscles work, that they work reciprocally. So many times people come in for treatment and I test them and their muscles are locked up. They don't have reciprocal motion and they have a lot of pain. Well, that reciprocal motion is very important to keep the pain under control. It's the reciprocal motion, the muscle contracting on one side and the opposite muscle relaxing so the first muscle can do its job. That's where the brain gets its signals. But when muscles are like this, when they're locked down on each side of a joint, the joint doesn't move like it's supposed to, the brain doesn't get lit, and that causes what we call deafferentation, a reduction of sensory signal. An afferent signal is a signal that comes into the cortex, and so deafferentation would be a reduction of that sensory signal. It's a big word, but that deafferentation is like deforestation, a reduction of trees in the forest. So when we have deafferentation, the brain isn't lit like it should be. As a result, it can't do what it needs to do, and I mentioned that's an inhibitory effect. And it lets things be that shouldn't be there. That's the brain trauma. So a blow to the head, many factors that cause that blow to the head, a tremendous ability to change a person's life, and the brain has an amazing ability to reorganize itself. And it will reorganize itself, but it can reorganize itself in good ways, and it can reorganize itself in bad ways. We call it plasticity in good ways, and we call it dysplasticity in bad ways. We want plasticity in a way that'll make things stronger and healthier. We want plasticity that makes the brain work more efficiently. But when the brain works in a dysplastic way, that's where you start to drive pathways that shouldn't be driven, or to not drive pathways that should be driven. And that's the microtrauma we're going to talk about in a minute. Okay, so this is talking about the innocuous traumas that can happen, and these are the things that drive the dysplastic pathways. Not a good thing. And it's painless, and it causes premature aging, arthritis, balance issues, sleep problems, memory issues, digestive trouble, and a lot more. So I want to talk about a research paper that it was one of the things that helped me write my second book, which is Receptor-Based Solutions. It's about functional neurology that I think every doctor should know. These doctors are psychiatrists from New Zealand, and they find in patients who have schizophrenia and affect disorder, obsessive compulsive disorder, and all these neuropsychiatric illnesses, they find that there's primitive reflexes that are broken down, that they're not working as they designed. And I'll show you primitive reflexes tonight. So when those primitive reflexes are broken down, they're the things that make up the neural fabric of your nervous system. They are there before you're born. They're there for a couple of years after you're born and you're maturing, and then they seem to disappear. Well, they don't disappear at all. The research papers call it that they integrate, and that's actually a more appropriate term because it makes us move in ways that we should move. But there's not very many people that talk about what happened. What do those movement patterns look like? As a result, these psychiatrists that did this research, they say that they see these in control people, in people who seem normal, but they also see them in people that have pathology. And they say, why do we have these things in people who have the pathology and in normal people? It's because we all use our nervous systems differently, like I mentioned. These different aspects of neurologic function are the things that cause us to be individuals. So we know how these primitive reflexes work, but here in their paper, they say that there's increased prevalence of age with lack of specificity on what are these reflexes. So I thought, We need to write that book. So that's why the book was written. And we're going to talk a lot about those reflexes in just a minute. So they're called cortical release signs. The cortex is supposed to be lit up, like I mentioned, and if there's deafferentation, then the cortex can't do its job, and it releases the control of what's underneath it. And that's the aberrant motions and the other digestive or emotional symptoms that would show up. So when a person has x-rays in their neck, the vertebrae, everybody that comes in, most everybody that comes in gets x-rays, and I go over them with them. The upside down V here is supposed to be there. These should be in the center line, and those are the parts of the vertebrae that stick out in the back. The bumpy part in your back is for muscle attachment. When you tip your head off to one side, we'll call this the right side, the spinous processes, these things here should couple or move to the outside of the curve. That's normal. So you see it's out here in the V, and this V is more center line. Can you see that? See it from where you're sitting? When it moves to the outside here in the neck, that's the correct motion. These should be out here. So these are not moving as they should in both places. You see all the movement here. There's not as much here, but there's more movement here. You see that breakdown in movement? Those breakdown in movement issues are what we're going to talk about. And this one's actually going in the wrong direction. And that's just one example of micro trauma. These signals that should be sent aren't being sent. So let's follow me closely here. If you tip your head to the right, and these spinous processes should go to the left, which is normal, even down here they should go to the left. Moving your head to the left, they should go to the right. But you see, this is actually staying in the center line. This one is over to the right like it's supposed to be, but this one isn't over to the right. So it's not coupling. In other words, every time that person tips their head to the right, their brain gets the signal as if their head went to the left. Can you see that? That's microtrauma because it's turning on pathways that shouldn't be on, and it's not turning on pathways that should be on. Right? You're all with me? That's the microtrauma. We call it discoupling, and that's normal. That is, we see it all the time, but it's not right. It shouldn't be there. And then here's an example of lumbar spine. In the lumbar spine, the low back, these should couple to the inside of the curve. So these are working properly. Well, these x-rays are of a 17-year-old boy who was playing soccer at a nearby high school. And he came in, and all he could do was lie down on the floor. His mom's with him. He worked his way into the office and up onto the table, and as I'm examining him, I said to his mom, I know he has lots of low back pain. It's obvious his low back pain is a big deal. And I can tell you he hurts here and he hurts here, and this is why. However, this is not a low back case. This is a neck problem. His neck is where the problem is. Now, his mom's a nurse, and she's looking at me like I'm a little crazy right about now. Dr. Allen, he's going in for surgery tomorrow morning, for exploratory surgery, because the doctors aren't able to find out what's going on with him. I said, trust me, let me work on him. We can get him back on the soccer field. And it was about 10 or 12 visits later, he's back on the soccer field. He got a scholarship to go play at a college up north, and he's back doing what he loves. Had he had surgery, it would have changed his life, because that problem was not a low back problem. It was a neck problem. Remember, those vertebrae up here are not moving as they're supposed to. If you take a cross-section of the spinal cord that's in the neck, the leg fibers are more peripheral, and the arm fibers are deeper on the inside. So if something's affecting the cord from the outside in, it's going to affect lower body before upper body. And doing exploratory surgery to his lower body would have showed nothing, because the problem was up higher up. So I was really thankful that his mom let me work on him. And so is he. So this is an example of the stressors that can get placed on a spine. As the vertebrae go opposite directions, here you can see that this would be normal, but this pattern is an abnormal pattern that creates stress inside the cord itself. Can you see how that would happen? It's not back and forth. This isn't a reciprocal pattern on the left. This one goes this way, this one should go this way, this should go this way, and this one should go this way. So it's backwards. Okay? So the clinically oriented reflex tests are very important for doctors to know, and that's why I like to do classes. I travel internationally to do classes and teach doctors what to look for. I'm amazed at the number of doctors that don't know that a low back problem can show up in the neck. To me, that's pretty basic. Pretty regularly, I see people who, when I do the muscle tests, there's weakness in the lower body and strength in the upper body, and I tell them, your low back pain, I see it, but these muscles in your low back, your lower body should not be weak. This says neck. And the doctors, it's like a light goes off in their head when they understand what's happening. And they no longer just examine the low back, they'll examine the neck as well. So some symptoms of concussion, unconsciousness, of course, that's probably one of the most common things that people know about concussion. But it can also be difficulty with new information, visual changes, headache, nausea, dizziness, tiredness, digestive trouble, a whole bunch of things. Brain dysfunction can lead to things that'll change your life. And the impulsivity is pretty common too. Brain dysfunction can mimic brain trauma, and this is exactly what I'm talking about. When the muscles don't send the right signal, it can mimic brain trauma when in fact it's just dysfunctional signal to the brain. A young girl came in the other day who had a disease, it's called PANDAS. It's a strep disease that young kids can get, and it brings on tremendous change in their nervous system. But the point is that while she was lying on the table, I stroked the sole of her foot, her left foot, and her toes flared. I stroked the sole of her right foot, and they curled down. Well, a flaring toe in a 16-year-old is a pathologic sign. It says brain injury. It says brain trauma. It's called Babinski's sign, and it's very bad. However, after treatment, when I stroked the sole of the left foot, her toes curled again, because it mimicked what was a more important issue, which really wasn't there. So these signs and symptoms of brain trauma are very common. You probably heard about check with your doctor before you do exercise. Well, in fact, you should actually check with your brain, because I think people over-exercise. Those people that come in whose muscles are all locked up are actually overtrained. Those people they do their exercise regularly and religiously every day, but the muscles are locked up because they've exceeded their capacity. They don't have enough energy in there for the muscle to release, and it's that energy that's required for muscle to get back into a contraction state so that it can do its job. It's called ATP. If they don't make ATP, the muscle can't release. It goes into spasm. And that muscle, although it's in spasm, it's actually shut off. It can be too weak and not supporting the joint as it should. So before you do exercise, check with your brain. Make sure your brain is receiving the nutrients and the neurologic signal required for it to be as healthy as it could be. Okay, microtrauma. Very slight, an injury or a lesion, small unnoticed issues. I've dissected hundreds of brains, and when you dissect the brain, you can actually see brain trauma. You can see, when you look at a watermelon and there's the black dots on the outside, and they call them bee stings. I've heard people say that a bee stung it. So those little black dots are what you see on the inside. And when you open up a brain, you can see little black dots, and those little black dots are microtrauma. They're like mini strokes. They're like areas where blood gets clotted and that tissue dies. So, and that's going to have its effect wherever that signal would go, within the brain or into organs or into muscles. And then there's the cumulative trauma disorder, where one thing after another that's uncorrected leads to the things that can mimic brain trauma. Difficulty with memory can mean that you're unable to remember simple things. in the immediate time zone, or you're not remembering things way far in the distant past. It can be either one. We call them retro and anterograde amnesia. So I wanted to show you a couple of more recent things that are going on here at UCLA. They're studying brain trauma and stress disorders. Here, this is the effects of multiple head trauma on high school football and soccer players. This is in Michigan, and this was from 2008. The point is that the brain's very important to keep everything under control. When the brain gets tired, things happen that shouldn't. Microtrauma. Okay. People ask me, so how do those muscles and joints work together? Muscles move joints. Joints don't move muscles. When the muscles contract and joints move, there's receptors inside the joint tissue and inside the muscles that are stimulated, and those receptors send their signals to various places. From the muscles only, the receptors go to the cerebellum. It's back here in the back of the skull. The cerebellum controls the muscles unconsciously, can control the joints and the receptors, and this is a way that we stay upright, for example. From muscles and joints, the signal goes to the thalamus. The thalamus is way deep inside the brain, and it's the last area that all sensory information goes through except the sense of smell. That goes someplace else. But everything has to clear through the thalamus. The cerebellum feeds into the thalamus, and the thalamus then stimulates the brain so that it can control the muscles to control the joints. Okay? Everybody with me so far? Let's go backwards. The muscles receive information from the brain, and the muscles receive information from the cerebellum. The brain gets information from the thalamus, which gets all information except the sense of smell from receptors, which are stimulated as a result of joint and muscle function. Okay? So those muscles are very important when it comes to understand what's happening with the brain. The thalamus oversees an area called the hypothalamus. You might have heard of that. People call it the master gland. It has so many different nuclei in there that control things like sleep and wakefulness, fluid balance. It controls body temperature, respiratory, heart disease, heartbeat, and so forth. The hypothalamus is very important, and it stimulates the anterior pituitary through releasing hormones that make the pituitary send out specific hormones to a target gland, adrenal glands, for example. And when the adrenal glands produce the hormones, those signals go back up to the hypothalamus, and the hypothalamus says, thank you, and it slows down the production of the hormones, and you come to a simple balance. Well, the hormones change slowly, but we can change the muscles quickly. The point is that when the brain works properly, all the rest of these signals do what they're supposed to do. If the signals to the brain, to the cortex, break down, then that brain can no longer do its controlling of the things underneath it. So the naturopathic address of brain trauma is to use nutrients, for example. They use a lot of other benefits too, but they try to repair the axons to make them connect up better. And it's that neuronal axonal connection that makes the brain work. Remember, we said there's so many billions of neurons, but it's the connectivity that's important. And when you lose connectivity, you lose function. So we want to increase connectivity, and nutrients can do that and help repair all that tissue. Bacopa is a real good natural anti-inflammatory herb. We use a lot of Bacopa when people come in to help slow down their inflammatory response. Omega-3 fatty acids, that helps to turn on certain neurotransmitters, and acetylcholine there is very important for spinal cord function. Plant flavonoids, ginkgo biloba, you may have heard of that before. It's real good for brain function. And curcumin from turmeric is a natural anti-inflammatory. Boswellia, also known as frankincense, works, and arnica, which is a homeopathic remedy, helps take care of pain. So healthier...
Doesn't the last one also help reduce bruising?
Bruising, yep. It's used in case of trauma. A healthier brain gives you better focus, sleep, behavior, memory. A more efficient brain helps you overcome anxiety and depression and all of the issues that we talked about related to traumatic brain. Learning about how your brain works is the first step toward controlling your life in a healthier way. So, let's ask a couple of questions. One question I get asked a lot is, how do you measure brain function? And we measure brain function by looking at muscles as functional neurology, but we also use the same methods that other doctors would use, a pinwheel, reflexes. We use tuning forks for vibratory sense, check people's blood pressure, check their postural abilities. It's called Romberg's test. We have them stand with their feet all the way together, arms at their side, and close their eyes. And often we see people doing this and they don't know that they're doing it. Why wouldn't they know that they're doing this? Why wouldn't they know? You would think that a person would understand that they're wobbling all over the place, but they don't know it. They don't know it because those incoming signals that should tell them where they are in space need greater muscle stretch to find out where they are, to send the signals. Remember, I talked about the maps that are in the brain. Those maps tell you where you are relative to where you think you are, and they should line up. But as a result of brain trauma, those often don't line up, where people think they're one place when in fact they're someplace different. And this is one of the things that can lead to a fall. I'm going to talk about neck receptors and neck reflexes and how they're supposed to work to help you catch yourself when you fall. And so many times they don't work as they're supposed to. So we use manual muscle testing and all other recognized neurologic tests to indicate what that person's brain is doing. We find the area or areas that are in trouble and then send the signal to those areas by certain movements or adjustments or nutrition if it's inflamed, whatever is necessary for that person. And often the treatments are not the same for any two people. They're all going to be different. So we like to measure things. We like to measure. A patient came in today and he had terrible posture. He's all hunched over. He does a lot of driving and sitting in front of his computer. And I thought for sure we were going to have a blood pressure problem, but his blood pressure was fine. But left uncorrected over a long period, that can produce blood pressure issues because of a breakdown of the way the brain works. A dysregulation of the outflow from that place called the hypothalamus, which can make blood vessels get too tight, and up goes the blood pressure. So we like to help people strengthen their physical and mental abilities, boost their immune system, improve their relationships, manage their weight, reduce risk of debilitating brain disease, and anything else that comes up. So let's do a couple of tests. Would you get Matt? I want to put him on the table. My son Matthew he's traveled with me in various places across the country, and he's my number one patient when it comes to demonstration. He's a very good participant. So we'll put him on the table. Is there any questions while we're waiting for Matthew? Anybody have any questions? A few of you have been treated and you've seen how it works. It's going to be new to you. Have you seen applied kinesiology done before? Have you seen primitive reflexes displayed? Very fun.
Actually, I thought that was my neck X-ray.
You thought that was yours? I see some neck X-rays that are they're really, really dysfunctional. Some patients, I tell them, never have your neck adjusted. This would be a very bad thing for you. And some people, they love having their neck adjusted, and it feels very good. Hi, Matt. Would you be my patient? Mm-hmm. You can set your book over here.
Show them about it.
And
I don't.
So lie on your back for me with your head up here.
Yes. Gallons of food every day, more than other people.
Gallons of food?
Mm-hmm. So I'm fit. That's why I'm huge.
Copious amounts of food. Here, scoot down. There you go. Is that comfortable?
Yeah.
Okay, but I don't want your head like that.
No.
Scoot down just a bit. Is that better?
Yeah.
All right. So let me take a muscle. Hold up here. Don't let me push. So this muscle is called the rectus femoris muscle. It's part of the quadriceps. You know the quadriceps are on the front of your thigh. The rectus femoris is one of those four muscles. It takes its origin on the hip bone and it inserts below the knee inside that bump. So we could say with Matt that those muscles are working fine. Now, every time a person turns their head to the left, it should cause muscles of extension to turn on toward the head rotation and the muscles of flexion to turn on the side opposite head rotation. If the head goes the other way, the opposite should occur. That's set in stone with, I hope it's not stone, that's set in neurology as a normal human movement pattern. It's supposed to be there. That's one of the things that helps kids turn over, for example. It's a movement pattern that God put in there to be a foundational issue with the human nervous system. And the books say that those go away. They get extinguished at about 6 or 12 months of life. Now, Matt, let's see what happens. Turn your head that way. So again, this is a flexor. Hold strong. Don't let me push. And it should be turned on. Hold this one. This is a flexor. Hold strong. And the flexor should be inhibited on the side toward head rotation. Turn your head the other way, Matt. Hold up here. Don't let me push. That muscle that was previously inhibited is now facilitated or turned on. Hold strong. And the one that was previously on is now off. And this is a normal pattern. Head straight ahead. Let's check another muscle. Hold strong. This is a big muscle that comes off the first 1/3 of the collarbone and attaches into the arm. Turn your head that way. Hold strong. Don't let me push. That muscle should be inhibited in the normal pattern. Hold strong. Don't let me pull. And that one should be facilitated. Turn your head the other way. Hold strong. It now becomes inhibited. Hold strong. And this one that was just a second ago inhibited is now facilitated. So these are normal responses to the tonic neck reflex. So let's consider that, Matt, you get to pretend now. Let's consider that turning his head to this side, hold strong, caused that muscle, and I'm not pushing as hard, but I'm trying to make a point. If that happened, we would say there's a problem with neck motion. And this is that person whose head tilted one way, but the vertebrae didn't couple properly. They coupled into the wrong direction. So turn your head that way again. Hold strong. This one should be strong, but relax. Keep your head that way. We're pretending. Relax. Let it go. And if that happened, we would say this muscle's not turning on properly. So then we go and investigate, where does that problem exist? Is it in the neck? Is it in the shoulder girdle? Is it in cranial bones? Is it nutritional? Is it a movement disorder? What is it? And try and decipher it out. Okay, let me show you another muscle test. You know how you go to the doctor and you're sitting on the edge of the table and they tap your knee and your foot kicks? You've all seen that? Well, let's check that. We're going to do the same test here. Hold strong. Don't let me push. The foot kicks because of the signal that goes into the cord and comes back down, and it turns on the muscle that's stretched, but the muscle that does the opposite activity should be inhibited. It shouldn't work. And by the same token, when the signal goes in from here and it comes and turns this muscle on, the one on the opposite side should turn off. Remember, there should be reciprocity. There should be give and take of muscle signal. So if I tap here, hold strong, that should be inhibited. If I tap here, hold strong. That's a strong muscle. We already established that one's strong. Hold strong. And that shuts off. So that's a normal response. We can do the same thing with any other muscle. If I tap the insertion here, hold strong, that should shut off. So this is a way we can look at the spinal cord and see if the signals coming into the cord and going back out again are appropriate. They come in through one area and they go out through a different area. If there's any problem in there, we can find it. For every time a signal comes into the spinal cord, there's 12 things that have to happen. 4 of them are to help arterioles to muscle. Those are the small arteries that are inside muscle. Capillaries to skin. That means the redness or the blood that you can see in the skin that fills those capillaries. Piloerector tissue. Those are the muscles that make your hair cells stand up. And sweat glands. And those things are supposed to be kept under control. But when a person perspires very easily, when a person gets goosebumps at any time, when a person has redness or blanching of the skin, when they have these disorders, you can say that their nervous system is not properly controlling those responses that should be kept under control, and here you have microtrauma. There's other things that should happen as well, but my point is, with those 12 things that happen inside the cord, 8 of the 12 have to do with muscles, and have to do with the muscles being reciprocal. So the spinal cord is a very important place that we examine with every patient. Okay, so I showed you just a regular muscle test. I showed you a deep tendon reflex. I showed you actually a crossed cord reflex. And that crossed cord reflex is when tapping one area, you can check another one to see if it inhibits properly. Let me show you one called the flexor withdrawal response. Hold strong, Matt. Good. Hold this one up. Don't let me push. Good. Now, if he touches a hot stove with his hand, what is his first reaction? To pull it away. So if you touch a hot stove, what is this action called? It's called flexion, right? You're flexing your arm to get your hand away from the hot stove. So if I mimic touching a hot stove, hold strong, a flexor muscle should turn on that side. Hold strong. Good. And when you touch a hot stove, you pull your hand away, you push, and you step back. That's the mechanism. Ouch, push yourself away and step back. So if I touch a hot stove and hold strong, push yourself away, the flexor should shut off here because extensors turn on. Do you see that? So flexor, ouch, hold strong, turns on here, but the protective mechanism is, hold strong, then the extensor turns on the opposite side. So we can say that Matt's flexor withdrawal response in his upper body is doing what it's supposed to do. If you touch a hot stove, push yourself away and step back with the same arm on the same side, what should happen to this leg? Hold strong. It should be turned on. This one extends, hold strong. So the flexor here should shut off. So we can now say that Matt's flexor withdrawal response is intact, and that has a lot to do with the autonomic display. Remember that hypothalamus signal that controls all your body processes? It does so without you having to think about it. This is a test for that. This is a test for, are his sweat glands working as they should? Do his hair cells stand up like they're supposed to? Does he regulate his arterioles to his muscles? Does he regulate his capillaries to the skin? Yes, those things are under control because this reflex that controls that tells us what that picture looks like is doing its job. So we can do the same thing with the foot. In fact, it's that Babinski test, stroking the sole of the foot, where that young girl's toes flared. We fixed that by fixing her shoulder girdle. Remember I said that the leg fibers are peripheral and the arm fibers are deeper on the inside? So we addressed the area in the cord that would loosen up and let this display itself right, and it did. We didn't have to address her low back, which is where the nerves come from, to go down to the leg. I want to thank you all for coming. This class, brain function is very important to me. You know, like I said, I've been doing it for 40 years, and I love it more and more.